Nigeria is among the 30 high TB burden countries due to limited access to TB screening and testing services. But with support from USAID, the National TB Programme, the Stop TB Partnership and aligned stakeholders, Bashir Ahmad, a local radiographer, is able to set up and run systematic rapid screenings in Nigeria's most remote areas. He is on the front line, saving lives, cycling to hard-to-reach communities using the ultra-portable digital X-ray system and computer-aided detection, or AI software.
It's my responsibility to take the examination in terms of position the patient, then we'll collect his samples. CAD for TB is really helping because actually it can detect TB at early stage. That's the first one. And secondly, the heat map can show you the patches around the chest. If there's any patches, you'll see it with your eyes. It's my town, my community, my people. So it's a dream. So I want to give back to them by helping them or by doing this work. It's my passion. I want to follow my passion.
Hello, everyone. Welcome to the Delft webinar, the first one of this year. Next slide, please. My name is Katyayini, and I'll be your host for today's session. Today's topic is quite an interesting one. So as our title suggests, from deployment to long-term impact, building sustainable screening programs through high-impact innovation, service, and support. What we want to address in today's session is essentially the importance of prioritizing high-impact investment in order to improve efficiency. We live in a world of global uncertainty at the moment. Financial instability and fragile health systems are at the forefront of it. And by integrating TB screening within broader health system, today, our speakers are going to be discussing how, particularly in high-risk populations, these tools can actually drive sustainable change. Next slide, please. Yeah. Before I go any further, today's webinar is going to be interpreted live in English, French, Spanish, Russian, and Arabic. So all our attendees, I request you to please choose your language, your preferred language, using the interpretation button below. The other thing, which is the QA. So by the end of the session, we are going to have a question and answer session in the end. So if you have any if you have any questions for any of our speakers today, I request you to please put it in the Q&A box. That's going to make sure that we answer your questions. And in case we miss your questions, please don't worry. We will be sharing responses to all the questions in our Q&A sheet that we will be sharing after the webinar. Next slide, please. So without further ado, I would like to invite our Senior Business Development Manager, Joao Pedro Neves, who's going to be talking about the importance of program continuity in the face of the tenuous funding landscape. JP, the floor is yours.
Thank you, Katya. Hi, everybody. As Katya mentioned, my name is Joao Pedro. I'm a Senior Manager here at Delft Imaging. And before we start with the presentations, I have a few words to say. We are meeting at an important moment for TB programs, as we are nearing the end of GC7 and planning for GC8. Across many countries, teams are being asked to do more than implement. Oh, sorry. Next slide, please. Yeah. Yeah, thank you. So the TB programs are being asked to prioritize, to make difficult trade-offs, to demonstrate value for money, and to protect the service that have the greatest impact for people more at risk. Next slide, please. That's why today's topic matters, from deployment to long-term impact. Deployment is an important milestone, but it's not the finish line. A screening solution only becomes meaningful when it's used, maintained, connected to diagnostic and treatment, integrated into national systems, and able to keep serving communities. Next slide, please. This is also very, very much aligned with the direction of DC8. The Global Fund's new language is very clear. Country-led decision-making, high-impact investments, sustainable program design, integration into primary healthcare, and so on. For TB screening, what does it mean for TB screening? So moving beyond isolated activities and building programs that are target, measurable, and people-centered and sustainable. Next slide, please. At Delft, we see innovation as part of that broader system. Portable X-rays, digital imaging, CAD for TB, CAD software, data tools can help programs to reach key and vulnerable population and high-burden communities. But technology alone is not enough. Long-term impact depends on service, on training, on capacity building, quality assurance, uptime, workflow integration, and the ability of national programs to own and sustain what is introduced. Next slide, please. We have great examples here. So today, during this webinar, I invite us to focus not only on what can be deployed, but on what can be sustained. Not only on how screening starts, but on how it continues. And not only on innovation as a product, but on innovation as a pathway to stronger, more resilient, and more effective screening programs. So today we count with some presentations from Malawi, Nepal, Nigeria, Uganda. You can see here on the screen some pictures of these countries, the activities that are happening on these countries. And now I would like to give the floor to the presenters today.
Thank you, JP. Thank you. Without further ado, I would like to welcome our first speaker of the day, Dr. Henry Luzze. Dr. Luzze is the Assistant Commissioner of Health Services, Ministry of Health in Uganda. And today he's going to be talking about improving TB screenings in Uganda and their experience with Delft Light, mobile clinics, and CAD for TB. Dr. Luzze, please take away.
Thank you very much. Please just make sure that I'm audible that side.
Yes, Dr. Luzze, you are. Yeah, we can hear you.
Oh, all right. Thank you for the opportunity and for inviting me to make this presentation on improving tuberculosis screening in Uganda and sharing the experience with the Delft Light, mobile clinics, and CAD for TB from deployment to long-term impact. And as you mentioned, I'm the Assistant Commissioner, the Program Manager for the National TB and Leprosy Program in the Ministry of Health, Uganda. Next slide, please. Yeah, as a way of landscape, I'll start with some of the challenges we experience as a country, that we have an estimated annual TB incidence of around 96,000 cases per year. With the notification gap, we estimate that around 10,000 cases are undiagnosed or unreported every year. We have high burden areas in the northern parts of the country, We have islands in Lake Victoria. We also have urban hotspots in the city and some slum areas. Traditional symptom-based screening, as we know, has limitations of low sensitivity, especially in asymptomatic populations. Next. This graph is showing us the estimated TB incidence rate in Uganda, and it is derived from the WHO Global Report of 2025. You can see that trend from 2010 to 2024. And in 2024, our incidence was slightly below 200 cases per 100,000. But also it's important to note that in that same year, we were able to detect only 88,000 TB patients with a treatment coverage of 90%, meaning that we still have gaps in our treatment coverage. Next. So following those gaps, we had a strategic response, including some innovative screening approaches. In 2020, we had a very big case detection gap of around 40%. So we needed to shift our active case finding using the left light digital X-ray backup at the facility and also in communities. Then we also introduced the mobile one-stop TB clinics, which are the trucks or the vans, and they introduced the CAD for TB, artificial intelligence software for the real-time triage with a threshold of 50 and above. And for every person who scored 50 and above, we would collect a sample that we would send to molecular diagnostic techniques, especially the gene expert, which is more accessible than any other. But also we looked at the issue of integrating these screening approaches to ensure that we provide same-day confirmation of testing and initiating treatment on the same day. Also, by doing this, we worked with a number of partners, including of the Delft Imaging, the US government, Global Fund, among others. The picture on the right hand is the one where we are launching the Delft light systems by the US ambassador and other partners in the Ministry of Health. Next. Well, this slide is intended to show how the country has been steadily progressing in the deployment of these systems from 2020 to 2026. Because of the experience we have been getting along the way, we have been able to convince a number of our partners to make sure that we procure more of these gadgets. And the partners that have supported us, as you can see on the extreme right column, is the Global Fund, the Stop TB partnership. We had also the Uganda Catholic Medical Bureau working with the government, with the German association. We also had the US government coming in as part of the supporters of this deployment of these systems. Next, please. Now, this shows us the timeline showing growth from 2020 to 2025. You can see the years on the extreme left when the system started. You can see the numbers we have been screening in the total screened column, and the abnormal X-rays, and the percentages, and the contribution to the TB yield. What is here to see is that we have been progressively increasing the numbers of people we screen. From 2021, you can see we had only over 5,000, but in 2025 we had 137,000. This means that we increased the awareness, but more important, we increased the numbers of the left light systems in the country, so that now we are able to reach more population. And if you see the totals below, you can see that over that time, using the left light systems and the CAD for TB, we have been able to reach over 250,000 people. And were able to get nearly 58,000 with abnormal X-rays. That is, if now we put our threshold to 30 and above, which is contributing to 22% as far as people with abnormal X-rays are concerned. And we're able to send a number of them for the molecular testing, and we confirmed 4,500 persons with TB, which is a yield of 8%. But in addition, we are also able to clinically diagnose 3,500 patients with clinical tuberculosis using initially these systems, which contributed to 8,000 TB patients and that were diagnosed and started on treatment. The importance of this overall is that these are community activities. It's meaning that most likely would have not reached these 8,000 people in communities if it wasn't for these systems. And they would be there still spreading to the communities. But because of this, we can go to the communities and we are able to screen people in communities who could not easily come to the facilities. Next. Yes, I just want again to demonstrate one other experience we have had as far as screening for people living with HIV using these systems and the card for TB. This was done beginning this year, from January to February and March, with screening within the TB clinic. So you can see at the bottom that 11% TB.
Dr. Luzze, yeah, there's a little bit of a lag. Can you repeat what you just said? I'm sorry.
Oh, with this slide or even before?
Yeah, just this slide.
Okay. What I'm saying is that one of the approaches we have started using this year is focusing on some areas where we can get optimal yield. And here I'm demonstrating from January to March, our screening for people living with HIV using the light system and the card for TB. At the bottom of it, you can see the summary that 11% yield from screening in chronic care clinics using the light systems and the card for TB. So it actually gives us a higher yield than going into the general population as we had already seen. Next. Yeah, now these are the key achievements that we've had ever since we've got the systems in 2021, that we have been able to reach over 250 people that have been screened, and we've been able to detect 22% abnormal readings and yielding 4,500 TB patients that have been confirmed with tuberculosis, which is significantly higher in people living with HIV, TB contacts, and the hard-to-reach communities. And on the right, you can see the pictorial of the van that we acquired from Delft with X-ray machines in there and the software card for TB into the communities, getting the people screened. These people are remote, they are in remote communities, they would not have been able to reach facilities easily. So this is one of the demonstrations that we can show. Next, please. Yes, so now this is another achievement of integrating the digital X-ray and the computer-aided diagnostic screening during the CAST. CAST is our community awareness screening and testing. And as a country, we do this every quarter, biannually. So every 6 months, we do the screening where we go to the communities and mobilize and create awareness and do the screening. And we are relying so much on the systems that we have. And you can see that the mobile X-ray and the card for TB patients of the 1,243 that were identified, which is 34% yield using the Delft systems and the card for TB. It also offers a faster diagnosis, which offers real-time card, which is reducing the turnaround time. And also we have the expanded access to people who don't usually come to facilities using our mobile clinic remote outreaches. This is data for only March, where we conducted this just 1 month ago, where we had this information from the different regions of the country. But overall, that's what we are able to get. Next slide. Yeah, along the way, we've learned some lessons that we would want to share. That these portable systems with the artificial intelligence combination works best in both community and also facility settings. We've noted the higher yield in targeted high-risk groups. Instead of going in any community, we've mapped out high-risk groups, including people living with HIV, the contacts of people with active tuberculosis, and the hotspots that we have been able to generate in the country. Then also the mobile clinics, plus the data-driven hotspot mapping, leads to the efficient deployment. What we have done, again, relying on the Delft and the AI, we've been able to generate or map out the hotspots in all the districts. We have 145 districts in the country, but we have mapped out the villages using this artificial intelligence, which is EPCON, to tell us exactly where TB is likely to be transmitting highly in the communities, and we focus our screening in those areas. The community engagement, of course, is very critical for the success of this. We have been able to engage communities, creating awareness, and also trying to tell people, to create awareness about the system, but also to reduce the fear of radiation with the systems within the communities. So these are some of the things that we do while engaging in the communities, because the question is of the radiation in communities, and so we need to create that awareness and allay the anxiety. Next, please. Yeah, so the impact on program and people, we have improved the equity now. We have better reach for men, better reach for rural populations, and the asymptomatic people. So reach for men, when we are now doing our targeted outreaches, we know where men go for some of their leisure activities. So we try to target them there, and most of the times they don't have the time to come to the clinics. So we go to them, and this has been a better way to address the equity issues and also to the rural populations. So this has contributed to reduction in incidence and mortality. So we have data which we are modeling using our community screening and treatment, which has shown that by use of these interventions, we are able to quickly reduce incidence and mortality. We are strengthening data connectivity. So the CAD for TB is integrated with the laboratory systems so that we can be able to connect the X-ray findings with the patient data and also the laboratory information. This is not so widely spread, but we see that we are going into that right direction once we can be able to link this data with the laboratory and the other clinical data for the patients. Then the capacity building, we have been able to train people to task shift, meaning that we are training people who are not radiologists or radiographers, but we are training the nurses and the clinical clinicians to be able to use these systems because they're easy to use. Otherwise, you will not be able to have enough human resource to use the qualified people. But the task shifting has really helped us a lot moving forward. Next.
Dr. Luzze, can you hear us?
Hello?
Yeah, hi. There's been a little bit of a lag. Can you start this slide from the beginning?
Oh, this slide?
Yes, this slide one.
Okay. So what I'm saying that since this year we have developed a surge plan to increase the access but also to optimize what we are doing so that we get better yields. So in our surge plan, we have identified 4 key populations that we want to focus on. For systematic screening, we are looking at people living with HIV, which is integrated in the clinical care clinics. We have also targeted screening at urban and peri-urban hotspots. As I told you, we have mapped hotspots using the EPCON software. Oh, please go back. Yeah, and then the other area we are focusing on is the prisoners and also the refugees. And we think by reaching those 4 priority populations, we should be able to reach around 400,000 screened per year. But these are only the priority populations. The screening in clinics and facilities will continue, and in some other populations. But these are just the 4 priority areas that I want to point out to you. Next. Yeah, we've had some challenges, and also we have the country level recommendations. On the left, you can see these are the challenges. On the right-hand side of this slide, we have the proposed recommendations. We have the delays in laboratory tests for samples from X-ray screening that are referred to for gene expert testing. Because when we screen the community, sometimes if we don't have a van that has got the laboratory, if you just go with the X-ray system and CAD for TB, you get the sample, but you have to take it to the facility. But now what you want to do on the right-hand side is to be able to couple this dict X-ray and CAD for TB with a molecular recommended diagnostic test for the outreach activities. Already we have 33 of these equipped with lamp equipment, and these are tricycles that can go into the communities carrying the portable digital X-ray, but also they have the TB lamp equipment. So we only have 33, but we are looking at making sure that we get more of those. The inadequate trained personnel to operate the digital X-rays, I've already talked through this. We have trained clinicians to operate the X-ray systems, leading to the task shifting we are doing. Then the other qualified people, we are advocating for recruitment within our local governments. Inadequate resources to support the community outreaches. We are engaging districts to leverage on the primary health care funds, integrate with other opportunities like child health opportunities, immunization opportunities, so that we can rely on those resources to do the screening for tuberculosis as well. Next. Yeah, the future opportunities we see that we need to expand all districts. So we think we have to get more of these systems so that we can deploy more and improve the access to the communities. We need to integrate the full linkage of CAD for TB with the laboratory and treatment systems for same-day diagnosis and the testing. We need to have the AI-guided hotspot mapping for targeted outreach and efficiency. We need to align to the GC8 funding cycle. We are seeing that now we are in the process of making an application to Global Fund for the GC8, and we see some opportunities here of trying to include our delight systems and CAD for TB. Then the pediatric screening, we need to innovate into the pediatric gap that we are experiencing, and also into the mouth disease application, because sometimes we screen for TB using the system, but we know sometimes it's not TB, so we need another addition that can tell us about other lung conditions other than tuberculosis. Then, of course, the sustainability, we need to have local maintenance capacity and domestic financing. Next. Yeah, these are the takeaways that I have, that Uganda has moved from pilot deployment to the national scale-up sustainable screening for TB using the Delight mobile clinics and the CAD for TB, which are proven to have a high impact innovation. Achievements are significant, but challenges remain, and we have opportunities ahead. So our call on action is collaborative learning from the global elimination for tuberculosis. Thank you so much. That is the presentation I prepared for this. Thank you.
Thank you, Dr. Luzze. It was really informative, and it's quite fascinating to hear how the progress is being made in Uganda. Before I introduce our next speaker, just a quick reminder on the instructions, because I see a lot of new people joining in at this point, or did join before I introduced everything. So today's webinar is being interpreted live in English, French, Spanish, Russian, and Arabic. So I request all our speakers to, all our attendees to please choose their language using the interpretation button. Also, I can see a lot of you have questions, and we'd love to entertain them in the Q&A session, so which we'll have at the end of today's webinar. So please add your questions in the Q&A box. If we run out of time, we will share the responses with everyone afterwards. Next slide, please. Yeah. Without further ado, I would like to invite Dr. Joseph Daniel from Nigeria. Dr. Daniel is the IHVN Program Manager, Adult and Pediatric Art in Nigeria. And today he's going to be talking about the efficiency gains from the utilization of AI-powered tools in TB and HIV program implementation in Nigeria, particularly how they've been using the EpiControl platform. Dr. Daniel, the floor is yours. Dr. Daniel, we can't hear you. Can you please turn on your mic and camera? Thank you.
Okay.
Yeah, we can see and hear you now.
All right, please confirm you can hear me.
Yes, Dr. Daniel, we can hear you.
All right, thank you. My pleasure. So good afternoon, everyone. Thank you for the opportunity to present at this Delft webinar. Today, I will be sharing our experience with EPCON, an AI-powered platform that has transformed how we approach TB and HIV case finding in Nigeria. Next slide, please. So my name is Daniel Joseph. I work with IHVN as Program Manager, Technical HIV, Adult and Pediatrics HIV. Next slide. So this is IHVN, and this is our mission statement: to be a center of excellence in providing health service implementation, capacity building and research, ensuring equitable access to high quality healthcare services through innovative and evidence-based strategies. Of course, this aligns with the mandate given to IHVN by the Global Fund to reach all vulnerable populations, pregnant women, adolescent girls and young women, pediatrics, and even KPs, including men who have sex with men, female sexual workers, and other in enclosed settings. Next slide, please. So IHVN currently implements the GC7 grant, which is a combined TB and HIV effort. IHVN is a current principal recipient on this grant, which has lasted from 2024 and will end by 2026. IHVN implements a nationwide coverage to TB, community TB testing, as well as the mother-to-child transmission, where it's expected to provide HIV testing services to 5.3 pregnant women and link about 42,000 pregnant women to treatment. Next slide, please. In our implementation, we work with 11 sub-recipients on the grant, and in coordination with the national programs we implement across the 36+1 states in Nigeria using these sub-recipients, where we implement TB, where we implement TB as well as PMTCT services across the 36+1 states, and in 4 states of Anambra, Gombe, Kwara, and Ebonyi states, we implement comprehensive HIV services across these 4 states. Next slide, please. So in the next chapter, I'll be discussing the outline for this presentation, which we begin with the challenges as well as IHVN's innovative solutions to these challenges. We'll talk about the EPCON platform, evidence from the field, the impact of the scale of implementation, as well as lessons and future priorities for IHVN. Next slide, please. So Nigeria faces a high dual burden of TB and HIV amidst malaria and other non-communicable diseases. Pregnant women, pediatrics, and adolescent girls are disproportionately affected. Our programs are constrained by 3 key challenges of inaccessible communities, limited resources, as well as delayed data insights. Can AI be a transformative lever to overcome these challenges and reach underserved communities? Our answer is yes. How are we doing this? The Institute of Human Virology of Nigeria is leveraging the EPCON AI and has demonstrated substantial gains in the Global Fund GC7 grant in Nigeria. Next slide. So what is EPCON? It is an AI-enhanced early warning and epidemiological surveillance platform that has been used by IHVN to predict using demographic and geographic health data of the population, where it generates TSN codes that predict underserved high-burden areas in the country. This is done up to the ward level, enabling proactive and targeted testing to be done across communities for TB and HIV case findings. The graph you see below is a heat map showing areas with high prevalence as well as high burden of specified diseases, especially HIV and TB cases, up to the ward level. At the upper right corner, you will see the enhanced heat map showing areas that are areas of vulnerability where our healthcare workers can find free of screen. So in implementation, EPCON has helped us to do a lot of hotspot prediction, helping us in identifying vulnerable populations at their local basis in the community. It has also enabled healthcare workers to be guided to specific areas for testing, and also provides real-time reporting in the community. This platform has also enabled us to integrate our HIV and TB surveillance in one single platform, therefore further enhancing integration. In the next slide, we'll talk about how EPCON works through a 4-stage approach. Next slide, please. So EPCON does this by integrating data that is fed to read from our national platform, the DHIS2, and also generates data from the epidemiological as well as data from the population. This is integrated into the platform, and the platform does a prediction using machine learning algorithms that analyze patterns and generates these codes from high burden hotspots. This is now fed to given to community health workers and ad hoc staffs in our programs, who then go into the community using guided Google Maps to find these vulnerable populations at their communities. In these places, targeted screening is then done for these populations that are found. Next slide, please. The The process of doing this is actually very straightforward. This data is fed into the EPCON platform, which uses AIs to generate these hotspots that predicts where the vulnerable populations can be found by these ad hoc staffs, and they go there to do the testing So looking at the national picture and works that have been done by different SROs on the program, we will see that the number of pregnant women screened has increased by sixfold, from 64,000 to approximately 428,000 pregnant women screened within a 6 months period in the introduction of the EPCON platform. It has also dramatically increased our presumptive to case ratio, dropping it from 74:1 to 19:1. This actually means that the number needed to screen and test a positive case had drastically dropped from 74 to 19 presumptive cases to one TB case. EPCON has also helped in ensuring that our TB case yield has improved 5% compared to the 1% we were previously having using conventional testing methods, where healthcare workers go into the community unaided and test using their intuition. Next slide. In the next slide, we'll look at TB case finding in pregnant women from a pre-intervention and a post-intervention using the EPCON platform. With this, we'll see that there has been a 34-fold relative improvement in TB case confirmation. We did a statistical analysis on this at a p-value of 0.01, showing evidence that EPCON has really improved our performance in TB case finding in pregnant women. The pregnant women that were identified within this period, a period of 2024, when EPCON was not in use, was about 1,543 pregnant women. Compared to when EPCON was used in 2025, we had 89,053 pregnant women who were identified in the community. Of that number of 50,000 pregnant women identified without the aid of EPCON, 47,601 were screened for TB. In comparison to when EPCON was used, we screened about 86,243 pregnant women. Of this number, without the aid of EPCON, only 1,434 presumptive TB cases were identified in the pre-intervention phase. But with EPCON, we were able to find 5,120 presumptive cases. By the end of 2024, only 2 cases, confirmed TB cases, were identified without the aid of EPCON. But when EPCON was utilized in our intervention, we had 277 confirmed TB cases. This translates into a 74.5% pregnant women identification rate, 81.2% screening rate, and the presumptive TB cases that were identified using EPCON rose to 257%. And while confirmed TB cases showed that there was about 13,750% improvement using the EPCON AI application. Next slide, please. In the next slide, we'll talk about AI-powered portable digital X-ray screening using AI-powered applications in the community. This has aided us in improving our adult and childhood TB cases in the community. And coming from the different states of implementation in Nigeria, we have seen very remarkable improvement in our TB case finding. In Katsina State, about 59,907 individuals were screened across 24 LGAs. Of this number, 49,920 were screened using the ComTB app and 9,900 through the PDX machine, which is also an AI CAD tool. 2,244 TB cases were confirmed in total from this intervention. Of this number, about 1,695 were confirmed using the ComTB app, yielding a 3% gain. But that which was done using the PDX with the CAD for TB, which is an AI-powered tool, we had an increase of 5.5%, yielding about 549 TB cases that were confirmed compared to the symptom screening that was done using ComTB, which was at 3%. This shows that EPCON improved our performance by 38%, giving us an efficiency gain way beyond the conventional method of TB screening. So that also improved our number needed to test from 29 to 18. In Bauchi State, similarly, an intervention that was done using this screening tool showed that 14,671 individuals were reached in the community using an outreach method. 3,270 presumptives were identified in the community. Of this number, 457 TB cases were diagnosed. 78 were bacteriological diagnoses, 379 were clinical diagnoses. With the AI assisted tool, the TB yield rose to 14%, and clinical diagnosis showed that 83% of the detected cases found using AI PDX, identifying more cases than the conventional. So while conventional screening relies on the WHO four symptom guide, AI-aided PDX improves efficiencies by improving the numbers that are screened, as well as the screening efficiencies and outcomes from these interventions. Next slide, please. In our PMTCT program, EPCON has been shown to outpace maternal HIV transmission in Katsina. This was seen in some interventions that were done in Katsina by Frank and others, by KNCV. Results emanating from this shows that hotspot detection using EPCON improved screening by 6 weeks earlier compared to conventional testing, which was just a reactive model of testing. The sensitivity emanating from EPCON showed that EPCON was 0.88 or 88% sensitivity compared to 64% sensitivity using conventional methods, which were community healthcare workers just identifying areas to go and do screening. The positive predictive value emanating from the use of EPCON shows that the PPV was 62% compared to only 41% using conventional method. Also, EPCON has aided the prediction of hotspots across the 36 LGAs in this state. Then pregnant women that were reached using EPCON compared to the conventional method shows that 2,109 pregnant women were reached in these LGAs within a space of 3 months compared to the conventional methods, which are facility-based and reactive, allowing pregnant women to approach the facilities before they are tested. This shows that EPCON is both proactive and predictive in our implementation, enabling us to have more efficiency gains in our PMTCT program. Next slide. In reaching our adolescent girls and young women, where we also utilize the EPCON platform, we have seen very significant gains utilizing the EPCON platform on our AGYW program. Prior to the implementation of EPCON on our program, we were lagging behind in the AGYW implementation because we were unable to reach this targeted but vulnerable population. So some of the studies we conducted using the EPCON and comparing it with our pre-implementation where EPCON was not utilized shows that AGYW reached with preventive interventions were just 4,180 compared to the use and utilization of EPCON, where this number and figure rose to 41,291. In comparison to AGYW that were tested without EPCON were 3,646. As compared to the utilization of EPCON, we are able to test 21,528 in adolescent girls and young women within a space of 3 months in 2025 when EPCON was fully utilized on our program. So what does this translate into? This shows that 887.8% increase in AGYW reach using EPCON was seen on our program. And also, EPCON helped increase the AGYW that were tested for HIV from 1,646 to 21,528, giving us a whopping 490.5% achievement. Next slide. Consolidating the gains that we have gotten from the use of EPCON from this selected but representative evidence, when we look at across all the 5 studies that were done, we see that there is consistent evidence that the use of EPCON is better than conventional testing. Therefore, EPCON delivers better coverage, better yield, and better efficiency. These numbers represent real lives, real women, real families who have been reached and would have been missed using our conventional and reactive approaches. So for the pregnant women screen nationwide, we have seen that on average, semesterly, we have seen 428,958 pregnant women being screened. And we have had 774 LGAs in Nigeria currently being covered. That's to say the entire country is now covered. Compared to our conventional screening, we just allowed the healthcare workers to use their intuition to approach this vulnerable population, therefore having missed opportunities in these communities. For the TB cases that have been found, we have increased by 5% positivity. Also, there has been a TB confirmation improvement of 38 times the conventional testing. And also, EPCON is able, on average, to predict hotspot detection by 6 weeks, and also has helped improve our ANC linkage rate from 92 to 95% to about 100% currently. Apart from what we see on the fee, we also have operational efficiency gains. Next slide, please. On our program, with the use of EPCON, there has been some reduction in monthly program review time because these things are done real time on the platform. The app predicts where healthcare workers should go to and therefore saves time as well as resources on the program. For our reporting compliance, when healthcare workers go into the field, reporting is always done. Real time, EPCON has helped in improving this reporting from the field, and also serves as evidence that work was done in communities because it is real time, and the platform enables us to also identify hotspots that have been visited historically. So it has also helped us to improve capacity building because for these healthcare workers who work in the communities, they are able to be taught on real time, as well as there is mentorship and capacity building for them to understand the platform and also be able to utilize the platform in getting efficiencies across board. Next slide. For the lessons learned for the sustainable screening programs that IHVN has recorded, and we are also advocating this to be implemented in other countries, we understood that integrating AI into existing systems is a way to go. Therefore, countries can leverage existing data systems rather than building parallel one. As you see, EPCON is linked to the Nigerian DHIS2 platform, which sieves existing epidemiological data for the country and uses it to make predictions for the program. So also, we can start with hotspot precision rather than mass screening. As Global Fund, we move into the GC8 grant. It is expected that we do more with little, and therefore, instead of screening so much using the conventional approaches, it is even better to look at efficiencies and effectiveness using AI-powered tools which can make prediction and leave us with some efficiencies gains. So it is also good to combine AI prediction with community mobilization. As you know, technology alone is not sufficient. Therefore, the success of the EPCON platform depends on trained community healthcare workers who are able to translate this into usable predictions. And our healthcare workers in the field continue to undergo capacity building for using this platform to make informed decisions in community. So it is also good to measure efficiencies on the platform. As we see, EPCON enabled us to reduce our presumptive to case ratio from 74:1 to 19:1. Therefore, in looking at efficiencies on our programs, we'll need to use AI-powered tools that can help us save resources as well as manpower time. Also, one of the lessons we have learned here is that the use of EPCON has also helped us to integrate our HIV/TB program. Therefore, we can look at our TB and HIV program in one platform that helps us predict disease patterns as well as areas of vulnerability on what platform. What are the future priorities for us using AI in our intervention? Next slide, please. So with the emerging field of predicting TB implementation science, what future priorities are we looking at? For IHVN, we have moved a step further to begin to look at areas where AI can be used in hyper-personalized interventions, where we can use AI to segment populations and tailor our messages as well as our intervention and services to suit our clients' risk patterns. So this is particularly important in our AGYW and PMTCT program, where these are key vulnerable populations that we are looking at. So we have also attempted to move from being reactive to proactive and predictive in our programs. The use of AI has allowed us to better approach our programming in the sense that we are able to think ahead of time, where we can find a larger population and where the risk patterns are more to find cases. So we are also looking at important areas in our service delivery, which include decentralized service delivery for our clients. Decentralized self-service involves leveraging AI for client-centered services that include HIV self-testing distribution. With AI, we are able to better predict where we can see hotspots, where we can see this vulnerable population, and better tailor our services. Therefore, in the implementation of our HIV self-testing program, we can better predict hotspots where we can see this vulnerable population, and then distribute our HIV test kits in those areas. This is also particularly important in our NSP program, needle and syringe program, as well as the medication-assisted therapy programs, where we can find this vulnerable population through AI prediction. We have also moved on from a manual way of programming onto an autonomous health system approach, where we can build AI recommended actions as well as automated routines, creating a self-reliant program that continuously improve. In conclusion, next slide. Our evidence proves that EPCON is a foundational enhancer of efficiency in public health. It offers a scalable, replicable model for other countries. For those preparing for GC8 and other large countrywide public health programs, the message is very clear. Invest in AI-driven screening platforms. They work because you will reach more people, optimize efficiency, and you will save more lives. Thank you very much. IHVN and its partners have no personal financial interest in the commercial success of EPCON app. Our interest is solely in their public health impact and this testimony of our use cases and successes in the field. This is an acknowledgement to all our implementing partners, our funders, and particularly the government of Nigeria. Thank you very much.
Thank you, Dr. Daniel. It's always insightful to hear how Nigeria is working towards eradicating TB and other infectious diseases.
Sure. We have a few questions for Dr. Henry from Uganda. Dr. Henry, can you hear me? Can I share some questions regarding your presentation?
Well, yes, I hear you.
Okay, great. So I will just read a couple of questions that we received about your presentation, and then feel free to address them, okay? So one of the questions was the daily capacity of the X-rays in the community. The actual average of X-rays taken per day, the CAD4TB version, and the cutoff score used, the threshold used during the screening for confirmatory test, and how many days per year the outreach activities were working.
Thank you very much for those questions. I guess I'm audible.
Yes, you are.
Okay. So the capacity for the systems we have is 100 per day, but practically most times we don't reach 100 per day because of the other issues. You know, the CMS workers have to do some work, they have to mobilize. So on average, what we have observed is 50, around 50 patients per day. But sometimes when we go out and the mobilization has been good and we extend the hours of working beyond the normal hours, we can reach even 110, 120 patients. But on average, we can take 50 patients. So the version we have version 7, which we are trying to upgrade to version 8. We are working with Delft so that we can have all the systems upgraded to version 7. That's version 8 that can capture other non-TB conditions in the chest. For the days we work, this has not been standardized for every facility. but we plan to have like one outreach every week for the facility. So if that's one outreach for every week for the facilities, but also at the beyond the facilities, we encourage the health workers to screen all the people that have come at the facility, whether they are the patients or whether they are escorting, because you know that even as symptomatic person, sometimes we find them with abnormal lung conditions. For the data, the X-rays have their system analysis management, analytic system management, which captures the X-ray information. But this is analyzed separately. It is not yet linked to a national data system. So we analyze it separately. We send to a local system called the Tuberculosis Info, TB Info, which this one now links to the national system. So we are trying to see that we can bridge this gap by having a system that can connect directly all the information of the patient, the national DHIS2 system. So that's what we have right now. Yeah. I think those are the questions I'm seeing. Thank you.
Thank you, Doctor. I'm not sure if I missed your answer.
I'm sorry, JP, but just to interrupt, our speaker has turned up.
Okay.
I'm so sorry for the slight mishap, but I will very quickly introduce Dr. Kuzani again. I request our producer to please load the slide. Yeah, perfect. Just to very quickly introduce Dr. Kuzani. He is the Deputy Director, Community and Promotive Health Services, CPHS, that is, and the Program Manager of NTLEP Malawi. Today, he's going to be talking about the implementation experience of the chest X-ray and CAD in Malawi's mobile diagnostic unit. Dr. Kuzani, the floor is yours.
Thank you. Can you hear me?
Yes, we can now.
Thank you. I apologize to everyone. I'm so sorry about that. Anyway, can we move on to the next slide? Next slide. So the mobile diagnostic units are an active case finding approach. What brought it about were findings from a prevalence survey that we did back in 2012 through to 2013, and which is the basis for the figures that were reported to WHO in 2014. Anyway, what that found was that we had been missing a lot of TB. We were finding less than 50% of what was possible. And we also found out that lots of people that we had missed were coming to facilities repeatedly, but we were repeatedly missing the opportunity to diagnose them with TB. And from all of that, and these findings about more TB in urban areas, in certain urban areas over rural areas, we devised this, the mobile diagnostic unit. So what you can see is it targets high-risk groups, and those high-risk groups are both in the urban and rural areas. There are a number of them. There are 12 for now, but originally, and this is back in 2018, there were 7, and they were deployed to the hardest hit areas. So when I say deployed, they're deployed permanently to these areas that were hardest hit. Because of the success we had seen with these 7, we then bought an additional 5 in 2023 and deployed these to borders primarily, but they too roamed around the country just like the original 7. Next slide. So what did we do? What we have basically is an approach that blends WHO's 4 symptom questions in parallel, at least originally, with a digital X-ray with a computer-aided diagnostic system that is running on AI. In this case, we're using Delft system. That was the original system we used for these original 7. So we had fixed X-rays in these trucks. We initially set it at 50, then later on at 60, and would have people come through and screen first through questions and then through an x-ray, and then give us a sample if they could. Please take note of that. And that would run on Gene Expert. We didn't want to leave the system completely, how do I put it, unsupervised, in a sense, the decision completely at the mercy or at the hands of the AI. So there was a clinician to verify and to agree. This also gave rise to clinical diagnoses. That too shall play an important role later. Next slide, please. So what did this algorithm look like? So the WHO symptoms, I think you know, they basically cough, fever, night sweats, and weight loss. So for those that we deemed to be high risk, we put this algorithm, this set of questions into categories. For those that we felt were high risk, and you can see who that is. And for anyone else, it made the basis for what we asked. And this is how it was split. So when we're facing minors, people living with HIV, prisoners, healthcare workers, you can see how it was used. It was any cough, it was any fever, it was any night sweats, it was any weight loss. Whereas in other settings, it would be, as you can see on the right, on the chest x-ray side. So who did we target precisely? We targeted urban dwellers in places that we knew to be hotspots. So this was a mixture of basically experience. You're looking at the places that have reported cases and putting them on a map and saying, okay, so we're seeing a lot of cases or a lot of presumptive cases come out of that area. That's a hotspot. Because we didn't have the means to always do this. So over time, this is a dynamic system taking note of each district's areas that are producing the most cases or producing the most people to be examined. Obviously, we give more credence to more cases from that area, but these are the considerations. So we had urban dwellers and hotspot communities. This especially applied to the rural part of our campaigns. We also targeted people living with HIV. We targeted healthcare workers, industrial workers, so people working at tobacco farms in the tobacco processing industry. We targeted migrants, hence the latter 5 that were stationed at borders, miners, ex-miners, and the communities around them. We targeted those that were internally displaced. So the last 5 years, I think you are probably aware, have seen what do you call them, cyclones off the coast of Mozambique. Mozambique has been affected the most, unfortunately, but Malawi has also faced some of that, and that's what we mean by internally displaced. So in the southern part of our country, the first part of the year would often see, over the last 4 or 5 years, between February and April, parts of the what we call the lower Shire, so the southern part of the country, would be inaccessible, flooded, and these vans would help in that kind of response. Others that we targeted were OPD clients, and then we also had periodically screening the biggest prisons. Next slide, please. So originally, our algorithm was in parallel. Started off at 50%, the default for the system. And this is what it looked like. You did TB symptom screening, and you did a chest x-ray. This is the current one, but let me just explain what came before it. So you'd have TB symptom screening followed immediately by an x-ray. And then that would be interpreted by the clinician. So what you had was, depending on what the x-ray said or what the screening or what the answer was from the 4 questions, that would determine whether we would ask you for a sample or not. We then switched to a sequential model. Why? Well, people would ask. We figured, well, this isn't research. And what we want to know is, do we need to investigate further or not? So we couldn't see a reason why we should continue to do these things in parallel if the four symptom screen already said yes. So we'll start with a four symptom screen. If it says yes, there's no need for us to do an x-ray. Well, we've gotten the answer we're looking for. We need to screen this person. We need to further investigate this person by collecting by collecting sputum. If it says no, on the other hand, we have an interest in doing the x-ray. And that would be the basis for the question of whether we investigate further or not. So we moved away from, regardless of the situation, of having this one in parallel to this sequential negative. Obviously, with these changes, humans will make their own decisions. They have their own beliefs. And so it takes time to get people to buy into this. I'm basically alluding to a need to continuously remind the colleagues in the field to use this however they feel. This point will become important in my conclusion as to what it is we see. Next slide, please. I've already spoken about this, so next slide. I think we can skip this. We all know this, so let's go to the next slide. So this is what we've been using. This is just to tell the story incomplete, though I'm going to concentrate on the Delft version. That's the one we have way more experience with. It's run from the beginning to date. And so this version is in 9 of the MTUs, actually. So even the 5 new ones, 2 of them still run on this, whilst another 3 will run on competitors. We went from a threshold of 50 to 60. We've been running this since 2018. This is the original 7. And we're giving you details as to which one of the vans don't have the CAD. What we're trying to point out is there have been intermittent or there have been points where we haven't had access to the CAD for whatever reason. It might be supply chain shocks, etc. We don't think we should ever rely on CAD alone. We can't. I suppose an argument can be made for doing so, but we think a human element should always be there. We think we should concentrate more on bacteriological, and again, this will become important. There's a strange phenomenon in which if you give a clinician, I suppose if you gave anyone a new shiny toy, that's great. There's an incentive to use it. And that makes up part of what we're seeing. At least that's what we think. I think we'll continue to investigate. Next slide. So how have we performed in that time? Like I said, we started in 2018 and we really started in June of that year. So you notice in 2018, we only screened 119,000 people. And that constituted 45% of what we wanted. We found 14,700 presumptives and they made up just slightly less than a third. We could only actually examine 9,200 of the 14,700, so about 2/3 were examined. We found 179 cases that were positive on GeneXpert. 3 of those came out with RIF resistance. And then we overall diagnosed 325 cases, which means that there was a lot of people who were diagnosed on the basis of something wrong on the X-ray. And I think this poses a question that I think becomes a problem for TB programs that we'll visit again later. Anyway, so that's what we have in the first year. And this is the year that it's at 50%. You look at the number of people that we're finding with that require examination, and notice that we went from 27, then 16, downwards to 11%. And this is that point we're trying to raise, that we increased the threshold. Now, again, this is an interesting thing about all of this, because if we follow the logic that we're doing all of this to find the missing cases, to find more men, to increase the total percentage, the total proportion of people that we find that are estimated, then logically that figure, that threshold should actually be set lower. You should actually have a lot more people that are being potentially examined or being labeled presumptive. However, this is the thing about reality, about our actual practices. We went from the 50%, rather than you think going towards 40 or 30 or what have you, towards 60, reflecting that there are other choke points, there are other limiting factors. And in this particular case, it was the cartridges. The more people you have to examine, the more cartridges you need to use, the more things that it triggers. We couldn't afford what this would have meant, and this is the pragmatism in play. So we went the other way. We know that scientifically, wanting to find more cases, let's go downwards, a lower probability score. But because we're being pragmatic, we're looking at the expenses of these tests. Yes, they're excellent, much better than what we had before, much newer. And what I mean is the Gene Expert. On the other hand, this is balanced by a cost of $7 to $11. That, whilst much cheaper than what they'll be if we didn't have the concessionary pricing, is still quite pricey. And it's still something that a TB program such as ours has to think about. So we adjusted it to 60, and that's how you see that the number of people, the proportion that we're examining from those screened falls dramatically. So we go from the 27% down to the 7%, and overall what we have is 11%, is what we find over that the 8 years we've been running this intervention. You see that over the last 5 years, it's been at 7% basically, with a NNS that is quite low compared to other points in time. But I suppose it's increasing, as you can see, and this might well expose the limits of these kind of interventions, at least in our case, not having, to my frustration, maps or areas of the country that are being divided by into certain units, so that we can better track hotspots. And I think we're getting to the limit of this and visiting the same areas. We need to find ways of better tracking geographically where these hotspots, what should we invest in. Next slide. So this is just to reinforce what I've been speaking of. There have been points where we've had the ability to run experiments and to do this kind of analysis and to see what it is we're missing by setting the probability score at certain points. And this is what we saw. So basically, the lower it is, the more presumptives we have, the more TB cases we should theoretically pick up. So if you take that, if we set it at 60 to 69, we miss out on the 804 presumptives we would have had to examine in 50 to 59. Conversely, though, that's only 2 cases we've missed out on. So this is the balance we're constantly having to fight with. That yes, we find more cases the lower we set it, but conversely, for the expense of the number of people we have to examine to find those 2 cases, is this actually worth it? And that was the question we were hit with when we apply the limits of our own budget to this program. Can we afford the additional costs associated with finding one more case? So 402 additional people, that's 402 potentially additional gene expert examinations that have to be done only to find one case. Can we actually afford that? And at that point in time, we couldn't. I still believe we can't now. So we've maintained the 60. And you can see why. We think incrementally we haven't lost as much. And I've already admitted what that we do know what the theory is, that we know in a perfect world we should set this lower. But given that we're constrained by real world issues like budgets, we feel that losing two whilst losing 401 examinations for every one case we find isn't a bad trade-off. Over. Now, next slide. I think this basically says the same thing, but maybe does it in even more stark fashion. But it's precisely the same thing. It rehashes the same argument that the lower we set it, the better it is. But at what cost, I guess, is what we all have to think about. As for us, we find that we can't afford at this moment in time to set this sub 50%, to set this below 50% and what it means. Next slide. We have done that in, so before you move on, we have done it in campaigns. That's when we've been able to see some of these figures, what we would have gotten had we set them much lower. So we have run our own experiments that have allowed us to see what are we missing what are we missing out on. But we remain at this point in time, we will stick with the threshold of 60. One of the interesting things we find is in vans that don't have, so those two vans that for a long time didn't have a digital x-ray, it's portable rather than the fixed variety that came originally, but essentially running the same kind of logic framework, as it were. We find that the proportion that are bacteriologically confirmed, the proportion that is clinically diagnosed falls dramatically. So you find that those vans have a higher proportion of those that are bacteriologically confirmed. And this, I think, goes back to, at this point in time, we're tempted to think that this is simply one of those effects of having a tool to use. If you give someone a tool to use, they will use it. And having seen a tool that is trusted like this flag that this area could be TB, they are tempted to then diagnose such people as having TB. After all, the goal is to find as many cases. We are pitting people against each other. As you know, competition brings out the best in people and their results. But in doing all of that, it also incentivizes the use of X-ray as a diagnostic. We often forget that it's being used as a screening tool, not as a diagnostic. But because it's there, you see this rise in clinical cases. I personally feel conflicted by this. On the one hand, as a TB manager, you could ask yourself, isn't this a good problem to have? On the other hand, is this fair to my patients? After all, this is a screening program. Is it fair? Would I accept, as I feel today, and I feel like I'm normal, that on the basis of an X-ray that I just so happen to have on that day, and there's nothing else wrong with me, that I be started on TB treatment? I think this is problematic in the sense of a screening program, and we intend to double down on stopping this because they are otherwise well. So I don't think it's necessarily fair. Then there's also the part about the rate, as at least, of TB in this country, as estimated by WHO, has fallen by 43% over that same period in time, from 197 to 113. So in that context, that we're actually quite low, we're finding people at an earlier stage. Should we be putting people on clinical treatment, on treatment from a screening program? In other ways, well, people on the basis of X-ray? I don't believe so. Next slide. One of the upsides of this, though, has been its effect on men. I don't know how many of you might be familiar with discussions that are happening in the SADC region, and I think the EXA region, so member states from those two areas, have run in recent years programs that are about minors, but have also been linked to missing cases and men. And so one of the things about this program, unlike the routine program that finds a lot more women engaged with the routine program than males, this one, the split is closer to 50-50. And unlike the routine program that sees a 2/3 split, so 2/3 of those we treat are male, whilst 1/3 of those that we examine are male. So clearly the problem is in males. In this one, it's even more extreme. Now, others might think this is bad, that it's 3/4 are actually male, that of the people that are linked to this program are males that we treat, also a quarter are female. I think it underscores just how much of a problem we have amongst males and how these mobile diagnostic units can be used to attend to that problem, to deal with that problem, to start to deal with that problem. If you consider that the mining industry and industrial output as a whole in most places are male-dominated fields, and by having these, we have to deal with male problems more so than female problems. We still have a problem of their engagement. We found that they prioritize making money over engaging with this, but it still gives us an avenue by which we can deal with males, and we can deal with them on multiple fronts. Over. Next slide, please. So what have we learned? There's no doubt that chest X-ray plus CAD improves the efficiency and effectiveness of TB screening. We find that we can find more presumptive TB cases. It can be a useful tool for improving the skills of clinicians who engage with it meaningfully. We found more cases are diagnosed from fewer clients. It is way more efficient than using just the TB, the WHO 4-symptom screening questions. This cuts out the chaff, as it were. But conversely, like I've said, if you give a clinician a new toy to play with, they will play with it. And so it conversely increases clinically diagnosed. We, on the other hand, need to diagnose, we need to reinforce our algorithm. There's a conflation of X-ray as a diagnostic tool. People keep on forgetting that it's being used to simply answer, should we examine further or not? Not should we treat. That's not the question. That's for the gene expert. So we need to double down on this, on explaining that to, and convincing our colleagues to understand that reasoning. A higher threshold, like I've already shown, lowers the cost of the program, but there is a cost. The question is, can you live with that cost? As if you're being pragmatic, we need to create EQA systems that look at this algorithm and adherence to it. We would like to see more geographical mapping of hotspots. We already have it. We'll show it on the next screen. Next slide. This is what we have in mind. We're with our partners, MLW, so they are an offshoot between the LSTM in Liverpool, the Liverpool School of Tropical Medicine, and the Kamuzu University of Health Sciences. And basically, they've been able to map out in red the presumptives and green the cases. And therefore, we could start to build up a map of where the hotspots are. This one pertains to Blantyre. Next slide. Next slide. The same things, just what we could potentially do with it and what it means for us overall. Thank you for your attention. Over.
Next slide, please. Thank you, Dr. Kuzani, for your presentation today. To all our attendees, we're really sorry for the extension of today's webinar. There were some internet issues that unfortunately couldn't be anticipated in advance. Last but not the least, I would like to invite our final speaker of the day. We have Dr. Naveen Shah. He's a former NTP director in Nepal, and today he's going to be discussing the active case findings in high-risk groups for TB in Nepal using Delft Light and CAD for TB. Dr. Naveen, can you please turn on your audio and camera so that we can continue?
Yes, thank you very much. Can you hear me?
Yes, we can.
Okay, so I'm Dr. Naveen Prakash. I'm going to present about how we are using our CAD for TB for our active case finding mainly in Nepal. This is the presentations. So next slide, please. So this is the map of Nepal. You can see we have a border with the China and India, and lower part where is the red, you can see in the red parts are mainly attached with the India, which is the high case load areas of Nepal for the tuberculosis, and in the mountain region is the upside towards the China. We have the highest peak also in Nepal, and our Delft imaging is even we have carried to the very high altitude also, and it is working very well. Next. So this is the overall like Nepal burden of the tuberculosis, like 67,000 cases every year we should have in Nepal according to the WHO, but we have detected only 39,151 cases. In DRTB, we are the high burden country for the DRTB. 2,400 cases are estimated last year, but we have detected only 625 cases. Next. So this is the treatment outcome. Like our treatment outcome is very nice, 92%, but the main problem is the case finding. Like we are missing 42% of the case finding. So we want newer technology to improve our case findings. Next. So this is the drug resistant TB. Like we have already told, the missing cases is very high. 625 cases only detected. Next. So drug resistant TB, our treatment success rate is 76% to 78%. Every year there is some vary. Next, please. So TB preventive treatment, we are also giving TB preventive treatment, and we are also doing the X-rays of the cases if the case is more than 5 years of age. So this is also helpful for us, this X-rays. Next. TB-free Nepal. We have TB-free Nepal initiative, and we have total 753 local level, and we have started this TB-free local level in 149 local level, and every local level have to do active case finding with the use of AI X-ray. This is mandatory for them, and they are using it, utilizing it, but we have limited equipments, limited X-rays. This is the main problem for this program to move faster. Next. And there's other activities like from the Global Fund supported sputum period, childhood TB screenings, TPT for children's, private practitioner engagement, active case finding in high risk groups, so active case finding in prison. So a lot of active case finding we are doing with the help of Global Fund support. Next. Active case finding in high risk group. This is a major event with the support of the Global Fund is going on, because in Nepal we are missing around 42% of the total cases in DSTB and 75% cases in the DRTB. So this is the main problem to our NTP Nepal. And after the use of Delft Light, the cost of camp, the active case finding camp has reduced significantly. Like in the past, if we go for the active case finding, and if we screen 100 persons, maybe 40 to 45 persons have the symptoms, and then we are collecting 45 samples for the molecular diagnosis like a gene expert or TrueNet. But now, after the use of the Delft Light X-rays, we are there. The score is more than 15, only 5 or 6 cases among the 100 screened cases. So we are sending only 5 or 6 samples, and we are getting the patient of 3 or 4 among them. So very high positive rate in the in the camp, and we can also reduce the cost of the camp significantly. So with the same budget, we are doing more active case finding camps every day. People's coming to campsite for screening has increased in the past. If we take the X-ray to the site for the active case finding, if you don't take the X-ray to the site for the active case finding, these people's coming for the camp will be reduced. So lots of patients, lots of people, they are coming to go for the X-ray to see not only TB but for also other diseases also. That's why the people's participation has significantly increased after use of this Delft Light X-rays. Percentage of molecular test is reduced, as I have told before, and positivity rate from the collected samples is increased significantly. Next. So there are 7 provinces in Nepal and more than 250 active case finding in each year in each province every year. So there is 250 working day in 365 days, and every day every province is doing one active case finding, because we have one this AI X-ray in each provinces, and the machine is utilized every day. The total 9 machine is there, and 1 in each province and 2 with the centers, and center is also doing active case finding every day. So around 250 active case finding in each province every year. So you can multiply to 50 into 7. So that much case finding we are doing in 1 year with the use of this Delft Light X-ray. Each functioning machine is occupied every working day for active case finding. And now just we have also purchased some more Delft X-rays, and 2 X-rays has already, we have given the order for the purchase of the 2 new Delft Light X-rays. Next. And wider benefit of this Delft Light X-ray, like helpful for diagnosing of the cases clinically. Sometimes it's very difficult to diagnose clinically, but after the use of the Delft Light X-rays, it is easy for the clinical case finding also. Easy to differentiate old and new lesions in the lungs. Like if you go for the molecular diagnosis, like the gene experts, the sample will be positive for many years. So, and that cannot distinguish whether the bacilli is live or dead. But if you go for the X-rays, you can compare the previous X-ray, and if there is a new lesion in the lungs or not, by that you can differentiate. So case finding has improved, like we have less false cases we are getting. Reduced false cases, which is positive in the gene expert, maybe due to the dead bacilli, is reduced significantly. Early detections before being symptomatic, so we can detect the cases before symptomatic. Like we have done the prevalence survey in the year of 2018 and 19, and we have seen 70% cases are asymptomatic, and that cases are missing if you go for the active case finding with the symptoms only. So after the use of this AI X-ray, we have a lots of helpful for this asymptomatic cases have increased, and there's a decreased transmission of TB. Like if you early detect the cases, the transmission will be reduced and the TB control will be better. Early detection of the lung cancer and other lung diseases, like we have lots of cases when we go for the camp active case finding. We have detected lots of cases of the lung cancer. So in earlier stage, so they can go for the surgical management, which is better for them. So not only this AI X-ray is used for the tuberculosis, but for the other diseases also. And we link the cases of the cancer to the hospitals, and sometimes we suggest them to visit the cancer hospitals, and they are doing that, and they're benefiting lot from them. Next. So this is the Delft X-ray camp. We normally go in the mountains and very hard to reach area where there is no services for the TB screening. We took the machine to the hard to reach area and we do the active case finding. Next. So this is the Delft Light. You can carry on the back and go for even on the motorbike sometimes. So 2 or 3 motorbike, we just carry it, pack it, and go to the, because in the mountain region the vehicles cannot go in the mountains, so we have to go by the motorbike. You can see there is a motorbike besides. So like this we can go to the remote places. Next please. So this is a huge people's coming for the active case finding. You can see the big queue there for X-rays, and we screen every people's in the camp with the X-ray. If you go for the high risk areas like where there is lots of cases, we can poor people, marginalized people, and this some monasteries, some religious camps. We can go there and we can do the X-ray of every people's. And if there is the score is high, we send the samples. We nowadays do not depend upon the symptoms. We only depending upon our X-ray findings. Next. So this is the X-ray doing there in some room by our staffs. Next. So this is the heat map you can see, and the score is there. So we are using for the CAD for TB. Next, please. So this is me just examining there. You can see there's me sitting up beside there and seeing the test X-ray. Next, please. So this is our medical officers. They are just seeing it. Next, please. Thank you. That's all from myself.
Thank you, Dr. Shah, for joining us. I know it was a tough day for you, Professor,
yes,
but I'm so glad that you could join us.
I have a sudden meeting with the minister and I cannot escape from that. It's a very important meeting. Suddenly, the minister has called me in the ministry, so it was very difficult. Sorry for that. Sorry, extremely sorry.
No, quite the opposite. We are just very glad that you could join us. Next slide, please. Unfortunately, considering that we have shot out of our time by like half an hour or so, we will not be having the Q&A session today. Rest assured, all of your Q&A questions have already been answered in the Q&A box. For everyone else who would like to have those answers, we will be sending out a Q&A session answer sheet, in our follow-up after this email. So worry not, you will have the responses alongside the recording of today's webinar. Once again, thank you to everyone, specifically our speakers, our interpreters, and all our audience today for having us and listening to us and engaging with us. We would like to continue this relationship, and I hope to see you all again in the next webinar. Thank you so much. Have a nice day. With that, we call it the end of today's webinar. Thank you.
Thank you very much.